Very good morning, all of you. I'm very excited to have you all here for this interactive session on FLACS, femtolaser assisted cataract surgery, with our distinguished speakers for the day. Commencing speaker of the day is Dr. Minu Mathan, phaco-refractive surgeon, Chaitanya Eye Hospital. He'll be speaking about femtolaser technology and overview. Welcome, Dr. Minu.
Thank you, Dr. Jaion. Welcome to this session of femtosecond laser assisted cataract surgery. So I am supposed to talk about an overview on this technology and the surgery part of it. Absolutely no financial interest at all. So we know that this laser acts at infrared 1030 nanometers, and femtosecond means minus 10 to the power minus 15. Hello, sir. And so that is that fast, just to show how fast this is and all this. So mechanism is it is delivered into tissue, plasma generated, tissue separation happens. Basically that's as simple as that. And you can create different patterns. There are in different company machines, different patterns are available. Anyway, it is a kind of nucleus separation in form of a cylinder or in form of chops or in form of softening into small cubes. And no financial interest, but this is the platform which I use. And so the LensX platform, it needs docking. It's a contact process. So you have a patient interface which has to come onto the eye surface, and it has to applanate on the cornea by contact. So this is how the patient has to look into a blinking light, which he may sometimes see, sometimes he may not see. But then still, if he keeps his eye steady and straight, you can always dock, especially in very small eyes, and you kind of so once you dock, you may see the centration of the limbus. So this has to be quite central, and then once it is done, should not get any air bubbles in the interface, and then you will see the marking of the rexus size, which you can make the position and the size of the incision. So here is the marking on the anterior capsule, where you can measure whatever 4.85, 5.1, 5.2, and incisions also you can make, and paracentesis even 1 or 2. And see, some patients, this is one difficult situation where patients cannot see specifically a spotlight. So we'll have to maybe redock and dock. This is one case where the docking is not very central. See, this space is more, so it is a little tilted dock. But then still we can readjust the location of the rexus and the nucleus treatment according to the position of the eye, because many times once you do, patient becomes more irritable, and also you may not get it right. So once or twice if you do it, still it is not possible, then you can proceed with this also. Here the problem is that he has a intumescent lens with clear or white fluid on top of the nucleus. So here you cannot focus on the nucleus. So that is out of the question. You cannot do it. You can do a capsulotomy, but here the problem is the cortex is fluidy. So once you cut, and some level it starts from below, and once it completes, this fluid starts coming out. Once the fluid starts coming out, two things happen. One is it blocks the laser. Second thing is the level of the capsule changes. So you finally end up with an incomplete capsulotomy. See the gush of fluid which is coming out. So the first point which opens up will get this fluid out. So then this happens. So many times yours will be incomplete if you have very intumescent leaky cataracts like this. And on our table, see, we are used to this kind of a look with the lumera and retroillumination. It will look so grand and nice like this, so lovely to look at. But then if we do a femto, and then most of the cases will look like this. So this will be a new feeling for you, with lot of air bubbles and different yellow color and no red glow and all those. But later on we'll get used to that. Sometimes, now it's very rare, but then still sometimes there can be meiosis. You would have done a 5 millimeter rexus, people have been large. You come to the table, the capsule will be over your iris, and the pupil would have become much smaller. But many of them respond to intracameral phenocaine, and if not, then you put iris hooks or rings to dilate. But then make sure you don't hook on the rexus margin also. Many times the anterior capsule will be free, and the rexus margin should not be caught within this one. So incisions, this is one advantage where you can see. Here it is as easy as this. You can just identify that you need to use should not use Sinski or just a cyclodylus spatula or something. So you have a pointed and an angulated one which goes into the plane of the corneal incision easily. So you can see now that this has been placed very anteriorly. So sometimes this happens when there is, especially when there is an arcus, and if you try to go anterior a little bit more, it goes too much anterior, and so I abandoned this. Nothing happens to this. So it is just like you have not done anything. Just make another paracentesis on some location close to your limbus. So sometimes when you are too late doing the surgery after the femto, you may lose this kind of, the bubbles inside is an indicator of where it starts and where it ends. So sometimes you may have to try to identify the location by drying it very nicely, and also epithelium has to be slightly peeled. And then here again, see the angulation of the instrument. So if you angulate it downwards, it will not enter. So we should remember that it's into the cornea, and cornea is bent upwards like this, and so your needle or your instrument has to go in that plane first, identify the plane, and then it goes in very easily. Sometimes it looks very difficult. Here again, this is a classical example of a large arcus, and you hit on it, never opens. So if it is very large arcus, it is just out of the question. It doesn't penetrate through opacities. So capsulotomy is another very good option where you can have, mostly nowadays, which are free floating capsulotomies. Now you can see that you can just peel it off. So sometimes when you feel that there is connection, so don't just pull off. I rotate it around like a normal rhexis, so that when you feel resistance somewhere, you can always do it right like a rhexis. Especially in intumescent cataracts like this, if you see, I always stain. I just don't pick up the capsule. So some areas, mostly around 90% will be just free. When you put visco, you will see it moving off. But then if it is not completely moving, that means there is a bridge or a connection somewhere. So identify the connection and include that connected area in the rhexis. It may become a little irregular. So go beyond it and include that and come. Now you can see, if you see very carefully, I am zooming up to show you that there is a small strand of capsule here. So if that was on the rim of the actual capsule, then it would be a weak area there. And so remember, so this is how it looks after the case, just to show you that it was a complete capsulotomy. But then if these kind of tags are there, during your chopping, these are weaker areas where already some spots are there and still they have not opened up, and they can be weak areas. So here again you see that there is a connection here, and in all the rest are free. So when I am catching onto the capsule, I don't just pull out, I just lift up that area and see where is the connection, and just go beyond the connection and include that area and make it a slightly irregular one, but then still see the part getting included in the rhexis, and it becomes more uniform. And this is how it looks at the end. So hydro procedure, many times it will be difficult to see because of the air bubbles inside, the fluid wave is not generally seen when there are a lot of air bubbles. But then we'll see the movement of the nucleus. You can just see the movement of the nucleus, and you can see rock the lens, and this nucleus, the air bubbles come out, and then your red glow is better. You can even repeat it. Nucleus disassembly, it depends on till where you have hit, but then maybe you can go till 700, 550 microns, and then the cut is not complete anyway. So you'll have to go through the chop and then hold it and then split it. So you can use pre-choppers. Sometimes the hydrodissection is not complete, because if you are not hydrodissected well, you could not see the wave. It will not rotate. But after you dissect once, one more fluid wave, 1 or 2 times you can hydrodissect again and make it rotate. And once you see that, see the central core comes off because you have done a central cylindral part, and then the others are all mostly pre-cut, and so you can easily separate. See, there's so much of air bubbles. See, when they are very hard cataracts and use a lot of energy to cut through, then you get a lot of air bubbles. Very disturbing it will be, but you can easily remove them, and during hydro you can rock the nucleus and bring out. So you can see the cuts are already done, but it's a grade 4 nucleus, and so you can see, once you open up, see the kind of air bubbles which come out from the nucleus per se. Cortex aspiration is a little different because it cuts through the anterior. When we have anterior and posterior offset, you get cuts through the anterior cortex also. So when it cuts through, you'll get a cut, so vertically cut edge of the cortex, and you don't have loose cortex to pull it. So if the pupil goes down, then it is we have to be very careful to go underneath the rhexis margin and aspirate. So careful not to catch the cortex, the capsule here. IOL implantation is fine. It looks very well centered and nice, and that is a major advantage of this. And see, in one case where I had injected an IOL into the femto, this one, see what happened when I'll show you, this is an intact rhexis, but then when I injected the IOL, it went in very fast. Sometimes it gets shot in like a rocket. And then because it hit on the bag, see this way it hit on the bag, and then I had a intercapsule tear. I can show you at the end. So just to tell you that this may not be as strong as we feel, and it's been published that there can be weaker areas. See the margin which is broken here. So I don't want to go into small people. You cannot be doing, if it is smaller than 4, it's as simple as that. You cannot do a capsulorhexis through the iris. That is not possible. Maybe you can do it smaller, do the phaco, pupil, get the pupil larger, and then extend the rhexis margin. Posterior polar is the greatest advantage. You can create a femto delineation and take out the nucleus like what you see here without any rotation or any hydro procedure. And subluxation also, you can locate the rhexis away from your subluxated area, and having a rhexis is very, very important to place capsule stabilizing devices. Thank you very much.
Thank you, Dr. Minu Mathan, for the exchange of knowledge. We'll have the discussion at the end of the session. Next is the keynote address by our most academically decorated person of the day, Dr. D. Ramamurthy, Chairman of Eye Foundation Eye Group of Hospitals. He will speak to us on role of FLACS in refractive cataract surgery. Over to you, sir.
Thank you so much for the kind invitation to be a part of this session. This is a topic given to me, and some of the points have already been eloquently covered by Dr. Minu Mathan. I think today cataract surgery has completely changed. It's not just about vision clarity where we remove the opacity in the eye, but it is also regarding vision restoration. And now it's more concerned with vision enhancement, where we try to give a 70 or 80-year-old the kind of vision he or she never had right through their lifetime. And that's what the expectation is also. And towards this end, I think laser does help us, because laser has already been connoted with perfection. And because of its increase in predictability, reproducibility, safety, the fact that you may be able to do the excellent phacoemulsification, but I find, at least in my hands, if I have a laser platform, if I'm doing 10 cases, in all 10 cases, I can get almost exactly the same results. It's not just the use of the femtosecond laser, but the fact that the most of the surgery, at least under the femtosecond laser, is image guided by high definitional spectral domain OCT, further enhances the quality of outcomes with these when you're using this platform. I think all of us are fully aware of the primary uses of this laser. Capsulorhexis, that you can get exactly the right sized shape and position of the capsulorhexis, because of which your effective lens position is accurate. The propensity for posterior capsular opacification is reduced because of the good overlap of the rhexis margin onto the optics of the lens. The asphericity is fully functional, and also the rotation of toric or multifocal intraocular lenses is completely avoided. Lens fragmentation, almost in all types of cataract, the amount of energy that you use is reduced by about 50% when you use a laser platform. Incisions, though much talked about, I personally have given that up because I always prefer a near limbal incision. I find that it's a little difficult to do it with the laser. So both with my LensX and with my Catalyst platform, I go ahead and create the incision using the conventional blade. Arcuate incisions, when you're talking about refractive accuracy and small degrees of astigmatism, is essentially a good tool, and I will be dwelling a little bit on that. And as far as the rhexis is concerned, those of us who are using this laser platform are used to this kind of a rhexis when we have once, especially the nucleus is removed, and this is obviously a great way to put in an intraocular lens. So the advantages as far as the rhexis is concerned is better circularity, better capsulotomy and centration on the pupil and intraocular lens, and obviously translating to a better posterior capsular clarity and better overall aesthetic appearance. And when you are at the end of the surgery, when you look at an intraocular lens placed in a capsular bag like this gives you a lot more satisfaction what you see over here. Though finally the post-operative results might be quite matching in these two instances. One of the ways I enjoy with my Catalyst is that the ability to tailor make your capsulotomy. You can either center it on the pupil, you can center it on the limbus, but I center it on the scanned capsule because that's the way to go, because that essentially means that you are extrapolating the dimension of the lens bag and centering the rhexis onto the capsular bag, because the intraocular lens is going to finally rest in the capsular bag, and once you center it on the capsular bag, that seems to be the right way to go. But when you come across a tilted lens, a subluxated lens, etc., then a custom-made capsular rhexis is possible. I think that's one of the greatest advantages of the laser platform when you're using in these difficult situations. When you are talking about a slightly smaller pupil, you can get a maximized pupil, and this video will show that. Essentially, I normally aim at a 5 millimeter rhexis because generally there is a tendency for the rhexis to retract, and because of about 5.3 to 5.5 millimeters, here you can see that it's coming to 4.5 millimeters. So I can pupil maximize it and essentially move the icon so that I am getting the maximal size of about 4.9 millimeters. And as we all know, when you have a 4.9 millimeter rhexis, then it's doable. As Dr. Minu rightly mentioned, less than 4 millimeters, I don't believe in putting hooks or something and taking the patient back to the laser. Then you just do a phacoemulsification. Anything up to 4 to 4.2 millimeters, you can go ahead and do that. And then with effective phacoemulsification techniques, with which you are all familiar with, that's a toric intraocular lens that has been placed inside the eye. And with a digital overlay platform, you can ensure that even in these cases, you are getting an excellent refractive accuracy. And Dr. Minu did mention about the vagaries of the laser and the fact that the capsule could be slightly weaker, but I think that's a thing of the past. Earlier, we used to have direct applanation onto the corneal surface, because of which there used to be mini distortions on the dismissed endothelium. This used to make aberrant pulses, because of which, not exactly on the capsular rhexis margin, but near to that also there used to be postage stamp perforations, and hence it was initially thought that the capsular rhexis created with the laser is somewhat weaker than what is created manually. But today, now we have either a contact lens or a fluid interface which is there in between. Most of the femtolaser platforms are gone on to this, which avoids the distortion quite completely. And this was the initial picture that you used to have, and it's essentially this which used to cause the aberrant femtopulses to fall on the capsular bag, on the surface of the capsule. But when you have an extremely smooth surface like that, this is sort of gone away. There are studies which have proven that the capsular rhexis created by the femtosecond platform is almost twice as strong as the capsular rhexis that's created manually. Having said that, most often the results of a study is dictated by whether you have the femtosecond platform with you or not. So suffice it to say that today there is no longer a controversy as to whether the femtosecond platform creates a weak capsular rhexis, because we have seen whether during intraocular lens introduction, whether you want to use a capsular hook, iris hooks, difficult situations, these capsules tend to hold up quite well. And laser arcuate keratotomy, I feel that when you want to debulk the amount of astigmatism, this is a great way to go. The fact that it's image guided, you have a very precise length and position as far as the arcuate incisions are concerned. Corneal thickness measurement, so that whether it's 600, mind you, here you are not placing it at the limbus, but you are placing at 8 millimeters or 9 millimeters. So you can measure the corneal thickness there and then titrate the depth to about 80% to 90%. It is also said, though I personally have not tried, depending upon the residual postoperative astigmatism, you can open up the incisions on the slit lamp about a week later, but I always open it up on the table. And essentially, it is well said that there is a loss of flattening effect if there is even just like intraocular lens misalignment, in case you are doing an arcuate keratotomy, and if you are doing a limbal relaxing incision, which I used to do earlier, but I have given up now, if there is a 5-degree misalignment, there is about a 1.5% loss. If there is a 15-degree misalignment, there is a 13.4% loss. Obviously, when you have the whole thing in an image-guided platform, then the chances of misalignment much less, and you get the incisions exactly where it is meant to be at exactly the depth it is meant to be in. And there are several different nomograms that are there. If you're using the conventional Donenfeld or Nickman nomogram, which are essentially meant for the limbal relaxing incisions, and you are moving the incisions at 8 or 9 millimeters, you reduce the arc length by about 33%. That is, if it is saying that you make a 15-degree arc length, you reduce it to 10 degrees. But you also have specific Julian-Stevens nomogram that's meant for intrastromal arcuates. I personally don't use it, but stick on to the Varion holiday nomogram that's incorporated in it, which essentially gives me the exact penetrating laser arcuates that has to be done. And suffice it to say, when you have a 22 degrees paired arcuates at 9 millimeter, this is just a thumb rule, you get a correction of about 1 diopter. But let me tell you, the functioning of these arcuate keratotomy, even if they are created by laser, is just like a radial keratotomy. You're not absolutely sure, depending upon the biomechanics of the particular cornea, the results might be quite variable. And also the initial correction that you get might also disappear over time. So whenever you have a significant astigmatism, it's a good idea to resort to toric intraocular lenses. This is the opening up of the incisions that I make right in the beginning of the surgery. Here it's at the 90 degrees axis, and I'm going to be seated temporarily and going ahead and doing the surgery. But even when astigmatism at the 180 degrees, which is against the rule astigmatism, which we come across most often in our patients, I routinely make this arcuate keratotomies, and after the implantation of a premium, in this case it's a multifocal intraocular lens that has gone in, I go ahead and open these incisions. I find that the position of these incisions, even temporally, is ahead of the temporal clear corneal incision that I have made. So I do get the benefit of these incisions even when the against the rule astigmatism is there, and it helps me to debulk the amount of astigmatism, which is more important when you are doing multifocal intraocular lenses. Up to about 0.75, 1 diopter of astigmatism, especially if it's with the rule, I go ahead and resort to these incisions. This is what you see on the first day post-operative. This is the ASOCT picture, which shows that it's about 80% depth. Nowadays, I titrate it to move to 85 to 90%. Just like the indications for toric intraocular lenses, it also is not just the magnitude of astigmatism, but it is also the axis of the astigmatism. Like in this case, you see that it's 160 degrees, which means it's a with the rule astigmatism. In spite of the patient having about 0.81 diopters of cylinder, no arcs is indicated in this case. This is essentially a readout from the Jaion. But while in a case of against the rule astigmatism, and as you can see over here, just a 0.51 degrees of astigmatism, you get almost a 22 degrees arcs, paired arcs that are indicated, which corrects about 1 diopter of astigmatism. It is because the against the rule astigmatism in the posterior cornea, which is about 0.5 diopters, is also added on. So essentially, it's not just using the instrument, you also understand how it functions, and preoperatively, you have to analyze it quite significantly. So it is possible to create the laser arcuate keratotomies from 2 to 11 millimeters. I usually do it at 8 millimeters. The arc length is, can be from 10 to 120 degrees, but I don't go beyond 35 to 45 degrees, because once you go beyond that, then I think the healing is compromised. It's usually 80 to 90% depth. I center it on the pupil, and it's usually a 90-degree side cut that's being used. And this is again, I think most of the points I have already said, so I'm not going to repeat them. So as regards the phacoemulsification process itself is concerned, I think Dr. Minu has already shown excellent videos on the laser. So this is what you see under the, when you have a soft cataract like this, then I don't do any kind of a cube formation, but it's just a sextant that is being created. I I do a hydrodissection through the incisions itself. Once I do that, I find that the entire nucleus just opens up. Essentially, it's like creating pizza pies. And this, as you just look at the CDE, it will remain at 0. Of course, it's a soft cataract. Quite often, you can remove this cataract even with simple phacoemulsification using very little power. But the fact that the nucleus has also been pre-chopped in this very precise manner does help. And the fact that you already have a 5.5 millimeter rhexis which can receive the intraocular lens again helps. As you can see, all I have to do after doing the hydrodissection through the central chop, I just have to separate out. There's hardly any division that's needed of the nucleus. And even in these soft cataracts, which sometimes can be a challenge, the removal of the nucleus and the rest of the lens matter can go ahead in an extremely controlled manner. Cortex evacuation is not really a challenge once you slip the aspiration cannula under the rhexis margin. This is again a toric intraocular lens. I think ASM will not go into those details now. And when it comes to a hard brown nuclear cataract like this, then again, I find that my phaco power usage comes down by about 50 to 60%. It's usually a grid pattern of 200 microns each is what I use, where the nucleus is essentially broken down to small fragments of 200 microns cubes. And then using the fundamental principles of phacoemulsification, where you do a direct chop and subsequently as posterior plane as possible, you go ahead and remove the nucleus. The purpose is not to show phacoemulsifications here, so I'll just go on towards the end of my this video. Here again, I think I'm going to be implanting a premium intraocular lens, and the entire process, let me tell you, phacoemulsification and laser cataract surgery are not competitive technologies but complementary technologies. Once you have used the laser optimally and use the right phacoemulsification techniques, you very often end up with optimal outcomes. And when it comes to a white cataract, I think one of the major applications of the laser platform is to repeatably produce the capsular rhexis of the size that you need. And you can see an intumescent cataract like this. And I'm able to remove the capsular rhexis, the capsule which is free floating over there, quite comfortably. And rhexis, I think I'll pass this. And when you are coming on to difficult situation, again, it does help quite significantly. I have 15 minutes? Okay. Okay. And as far as the published literature is concerned, there have been a lot of controversy. And there are several studies which have shown both for and against the usage of FLACS. These are some of the initial papers which showed that the usage of phacoemulsification essentially, for use of the laser platform, essentially enhances results. But one of the studies which created a lot of attention, and rightfully so, was the multicentric studies which was conducted by ESCRS, which showed that the laser has no advantage. But mind you, this was not a randomized control study. There was no strict case control. Multiple centers post-operatively the outcomes were analyzed. The FLAPS groups had a far higher number of patients with previous keratorefractive procedures. Then the FLACS group patients were also much younger. Maybe they are the patients who could afford this. And also, there are several different parameters which we considered extremely important for premium intraocular lenses that were not taken into account. So essentially, when you have a LENSA platform, several different platforms have come up with different advantages. You can create a small nick like this, and this helps you to position your toric intraocular lens in the exact position. And now we have the femto LDV platform. This economics is obviously a concern when you're using the femtosecond laser. The fact that we can use it both for cataract and cornea, it's also mobile, and we can transport it to different centers, enabling us to get the right results does help. This is the kind of results that you often get with when you use the LRCS platform. Essentially, to conclude my talk, do I consider LRCS an advancement? I'm using it for almost a decade. I definitely think so. But does everyone need it now? I don't think so. Is LRCS the platform that all of us have to adapt in the future? I think only the future will tell. Thank you so much for your kind attention.
Thank you, sir. Thank you for the elaborate coverage of femto. So I think we'll go ahead with the talks and come to the discussion at the end. So when Dr. Anaka Herur is setting up her presentation, sir, what I wanted to ask, one point is, do you think that there is any reason why a femto-rhexis margin will be stronger than a tear?
I think that's why I immediately qualified by saying it depends on who is publishing the paper. You know, this particular paper was to some extent industry sponsor. I also don't believe that any reason a femtosecond platform laser should be stronger than a manual rhexis. But one thing is for sure, that the initial concerns about the rhexis being weaker is gone away with, and nowadays we all consider that irrespective of the way the rhexis is created, with both the platforms it functions quite well.
Thank you, sir. So now we'll welcome Dr. Anaka Herur from Mumbai, Anil Hospital, Mumbai. She is a member of Academic and Research Committee, AOS, and is a very good surgeon and a very nice speaker. So she'll talk on special situations in FLACS. Over to you, Dr. Anaka.
Very good morning to all of you. At the outset, thank you KSOS team for inviting me here and giving me an opportunity. So I'd be speaking on FLACS in certain difficult situations, no financial interest. So this was a patient who was operated for an IPCL in 2014, and then she came back to me with a nuclear cataract. She had a very high myopia to start with. We did a specular biomicroscopy which was normal. So these are some changes because we were contemplating doing a FLACS procedure. We're changing the pulse energy, as you can see here, from 4 to 4.5 microjoules. And then we go on to the, this is the Catalyst platform. The most important thing here is the OCT identifies the anterior surface of the IPCL as the anterior surface of the lens. So we have to manually change it, otherwise you would not get a capsulotomy. So this was the procedure done, the changes that were made. And once we go on to the operating table, we first stain the anterior capsule and then go ahead. Now, I was sitting temporally, and now we first bring the IPCL into the anterior chamber and then above the iris and then make it vertical. I then go ahead and remove the capsulotomy flap. We need to be very careful in these situations because there is a slight reduced visibility and little bit of the cortex also has been disturbed, and I'm doing phacoemulsification underneath the phakic IOL. Now the reason is because this was the first generation IPCL and I thought it was a rigid one, so I would have to extend the incision before I go ahead, and that is why I didn't want to extend the incision. That is why we are doing it. But you can see also that there is an anterior capsular tear extension. So even if it's a LRCS platform, we need to be very careful about this. We are now removing the phakic IOL with a hand-on-hand technique. Be very careful to introduce viscoelastic before you remove the probe and keep the irrigation on, and then we are putting in the intraocular lens 90 degrees away from the anterior capsular tear. Post-operatively, patient did extremely well. Now this was another patient, a 49-year-old male patient, a one-eyed, who had both RK as well as LASIK done. So he first had a 18-cut RK done in 1989, and a few years later he was also operated in the same eye for LASIK. So you can see this was the lower one is the eye which is not seeing, it's the RD, old RD. And then this was the patient where you can see a lot of metallic deposits in the interface in the stroma. So here this was the ablation that you can see on topography, and this was the pentacam holiday IKEA report. You can see a lot of keratometric variability. So we gave him a guarded prognosis also. The most important part here is also the biometry, because it was not only post-RK, it was post-LASIK also. So if you see the Barrett-Ruque, for the post-RK and the post-LASIK, it was giving us totally different IOL powers. So here it was 21 with the Barrett-Ruque, whereas in the post-LASIK formula it was 23 and then 27 with the Higgs L. So we also used the ASCRS online calculator for both post-RK and post-LASIK, and you can see there was a difference. In the post-LASIK, it was giving almost around 23, 24, and the maximum was around 25. So to be on the safer side, we kept it a little myopic and used a 25 diopter lens. You can see the OCT was showing those metallic deposits in the interface. Again, we used a FLACS in this procedure, and we had to make certain changes in the settings also. The segmentation repetition was increased to 4, anterior pulse energy from 8.5 to 9, and then the vertical spot sizing from 35 to 30, so as to get a better cut. So here again, the capsulotomy incision depth from 600 to 650, pulse energy from 4 to 4.5 microjoules, and then we went ahead with the procedure. So this is the Catalyst platform. You can see, obviously we do it in another OR, and then you have the OCT image guiding system. There's not so much of difference in this patient, but we thought maybe because of those metallic deposits in the interface, it could hinder the capsulotomy. But fortunately, when you see now during the surgery, again we stained it first, and we did it with a scleral tunnel because there was an 18-cut RK, and we didn't want to do a limbal one for the fear of opening up of the incisions. And now we are removing the capsulotomy flap. Fortunately, it was a complete capsulotomy, as you can see here. And as Dr. Meenu also was saying, you can see that because of the air bubbles, you don't really have a red glow in the beginning, but once those air bubbles are removed, then the red glow increases. So with the 23 gauge microforceps, we are just peeling off the capsulotomy in a circular fashion. Remember not to pull it because it can cause an anterior capsular tear. Rest of the procedure is almost the same, the phacoemulsification and the intraocular lens implantation. Now because there were these RK marks, we need to be a little careful so as to not open up these incisions. And this was a patient with a very high myopia. You can see how the pupil is coming down each time we are removing the irrigation. Fortunately, the patient did extremely well, and we were happy to see that even post-op, he had an unaided of 6/9 vision. Now, this was a patient of trauma with subluxated cataract, and the advantage of a femtosecond laser is you can actually center it on the scan capsule, and as we know, in such cases, the capsulotomy is the most critical part because we are also planning to put a CTR. So we are first anchoring it with the capsular hooks, and now we are putting in a CTR so as to give a good vertical and horizontal support to the capsular bag. Once that is done, then going ahead with the irrigation aspiration. Many times, if the cortical fibers are cut vertically, what we can do is you can go in with the polish mode, loosen up the cortex tangentially, and then aspirate it. That gives a more safer way of doing it. Then the capsular hooks are then removed, and then you can see that the IOL is well in place. This was a patient with an iris coloboma, where we are doing a FLACS procedure. Inferiorly, you can see that there is a coloboma, but fortunately, there was not much of phacodonesis at all. And during the surgery also, the lens was quite stable. So we are now removing the capsulotomy flap and going ahead with the phacoemulsification. And throughout the procedure, the bag also is quite stable. There was no sign of any zonular weakness apparent there. So once the phacoemulsification was done, the decision had to be taken whether or not to put in a CTR. But because the capsular bag was quite stable, we decided against it, and then completing the irrigation aspiration. The part of the cortex in the colomamatous area was dealt with at the last, and then we put in intraocular lens. This was the white cataract patient. It has already been shown earlier by both the speakers. So basically, sometimes you can expect that there could be tags, and we need to be careful here so as to not cause an anterior capsular tear. Rest of the procedures remain the same. The nuclear disassembly is not really that beneficial in such kind of cataracts, but definitely it makes things easier with a very good capsulotomy in the first place, because there are these intumescent cataracts which are very high propensity for an Argentinian flag sign, which can itself jeopardize the visual outcomes. So going ahead with the next, this was again a patient with RK marks, but since we have already seen earlier, I would not go ahead and complete this. Only thing is, it is not actually hindering so much the penetration of the laser. So it was found that the capsulotomy was complete even in these patients. This was a patient with a very hard brown cataract, a very demanding patient. He was actually a police inspector. And otherwise, without an LRCS platform, people would actually go ahead with asking for an SICS or increasing or giving even a block. But this was done under topical with the femtosecond laser. So it makes things easier. This is a place where we are also using the softening procedure. So you have cubes, and it's very easy to just separate out the pies from each other, and then it becomes more easy so as to reduce. It also reduces the phaco energy that is used in these patients compared to doing a phacoemulsification. So once these are patients who are very demanding, and this patient also was posted for a multifocal intraocular lens. So it is very, very important to have a perfectly centered capsulotomy and a good visual outcome, because in such brown hard cataracts, you can also expect some kind of corneal decompensation if there is a large amount of phaco energy used. So to conclude today, cataract surgery is more often a refractive surgery rather than just removal of cataracts. And my indications for femto is basically in those patients where you want a reduced phaco time, like a hard brown cataract, or patients who already have a compromised cornea, like a corneal guttata, where you need better centration, like you have a multifocal IOL, premium toric IOLs, multifocal toric IOLs, where you have a subluxated cataracts, and definitely in posterior polar cataracts. So with these platforms, we can actually go ahead and give better precision and better visual outcomes to our patients. Thank you so much for your kind attention. Thank you.
Thank you, Dr. Anaka. I think next is talk by Dr. Sai. While he is setting up, one one clarification on this. Have you seen this retained small cubes of nuclei when you do it on these kind of very hard cataracts?
Yes, sir. So I think what we need to do is do a good irrigation at the end and then be very sure that all those cubes have been removed. Sometimes they can actually go and hide underneath at the periphery, but then with time we, learn to clear them up. So it
The
doesn't
only thing is
really.
we need to
I mean,
remember that this may exist and they stick onto the iris underneath, and also washing is
yeah,
a
washing
very,
is
very
important.
important thing to do with this.
Yeah.
Thank you very much. We have not used catalyst. I have not used, but I was just, sir was also telling about the scanned capsule
Scan capsule.
margin. What is that? If there is no subluxation, if the iris is completely covering the equator, how do you get that scanned?
So we have 4 modules where four options. You can either center it on the pupil or on the scan capsule, or you can do a custom this thing centration. But we usually keep it on the scan capsule so that it is centered well on the bag.
That I understood, but what is this, how do you go till the equator of the bag when the iris is over the swan? How does
No,
it
you
scan?
don't have to go to the extent. You just select that option, that's all. It automatically selects the place where you do it.
I was wondering how does it automatically scan the lens? The available pupillary area. What is
Yes, yes. There's also a tilt compensation. So if there's a tilt in the lens also, it will compensate for that. Thank you.
Thank you, Dr. Anagha. It's a very fine discussion. Let's move on to our incoming KSOS President, Dr. Sai Kumar from Giridhara Institute, Cochin. We don't need to introduce him, but then he'll talk on phaco cataract surgery versus femto cataract surgery.
Good morning, ladies and gentlemen. Thank you, Jason, for having me in this talk. I think almost 90% of what I want to say has already been covered, whether it is the FLACS procedure or the advantages and things like that. So basically, my talk is phaco versus FLACS, which means that do you really need FLACS in an experienced hand? Does FLACS make a real big difference? So that is the main crux of what I'm trying to deal with now. So very frequently, whenever we talk about femto, these are some questions that are always asked. Is FLACS really a game changer? So especially it's an argument, over a drink with people who have femto and those who don't have femto. So, the first time one tells you that you have been doing cataract for 28 years now, do you really need a femto? Can you give the equally same results without femto? Is it worth the extra money that you have to spend for a femto? Is it more time consuming and difficult? Anaka told that she would prefer to do it in patients where the surgical time is less, but if you add up the time of the laser procedure plus the surgical time, I'm sure in most cataracts, the total time is definitely more than in a routine phaco. And are the long-term results different? I think this is one very pertinent question that needs to be addressed and answered by all of us. Are we really looking at a different post-operative results 5 years, 10 years down the lane? Do the femto cataracts or the femto results do different from the routine phaco? So we know that, what all the femtos can do. I'm not going into the details again. I will just briefly, show, this is we may not use all the steps in all the cases, but this is where we have used, all the steps. These are the side incisions. Like Minu told a few times, when the side incisions don't open up, or sometimes the side incisions are very close to your main wound, I abandon them and go with a separate incision. Now I just check the rexis margins with a Sinski hook just to make sure that it is clear. And I am always a bit skeptical about hydrodissecting when there is a lot of air. So I just make an initial trench there and separate, and then let out the air and then do a hydrodissection. So that hydrodissection separates those two hemi pieces, and then along the margins of your initial cuts, you can easily go ahead and remove the nucleus. So the phaco time as far as the actual procedure is concerned is definitely less. The phaco energy used is definitely less, and that is, you know, one of the biggest advantages of femto over a routine phaco emulsification. Now, regarding multifocal and premium lenses, Ramurthy sir has also talked in detail about that. So, in cases where you have to implant these premium multifocal lenses, sometimes these multifocal toric lenses, you need a nice good rexis which overlaps the lens exactly a millimeter from the edge of the optic. Definitely the long-term centration of these multifocal lenses are definitely better when you have a neat round rexis. Most of us can do a neat round rexis even in a routine phaco emulsification, but then there are situations where it may go slightly to one side, slightly to the other. There may be slight exposure of the anterior capsule edge. In those situations, definitely femto has an advantage. Posterior polar cataracts, Dr. Minu has already shown that. I am not showing that video. So this is, usually the cylinders are used. I don't routinely use the cylinders. I use the routine cuts in femto, in PPC as well. But they also, without doing any sort of hydro procedures, any sort of hydro dissection or delineation, you can slowly bring the pieces with your Sinskey hook or a dialer. You can bring them into your phaco probe and aspirate safely. And needless to say that whenever you remove out the probe, always fill the chamber through the side port with a viscoelastic before you remove your phaco probe. This is an intumescent cataract. Again, this is actually Dr. Minu's video. So this is, actually I think Minu has shown it in this talk. So this is a great advantage in intumescent cataracts where you can do a very good rexis. These are cases where you might go into an Argentine flag sign or a rexis rip-off, and so here you can use it. A very rare indication that I wouldn't say that you should buy a femto machine to do this. This is a case of capsule phimosis. This is a young lady who had intraocular lens implanted about 6 months back, and in a very, very short period of time, the capsule went into total phimosis. So, and I was just wondering whether the femto can cut through the capsular phimosis and whether we can, regain a nice round opening of the phimosis without doing much of cutting. But on the table, I found out that it was actually, there were areas where the femto laser had penetrated the capsule, and there were areas where femto laser had not penetrated the capsule. So I had to cut, some of these. Video plays in. Yeah. So if you look at that, areas in the anterior capsule which has been cut by femto, and there were also areas of phimosis which are not cut by the femto. So in these cases, I had to really go in with a micro rexis scissor and cut the rexis at the areas where the femto had not penetrated. So other difficulties are, again, as we have all mentioned, a small pupil. I recently had a half rexis. But surprisingly the lens was cut. So normally when you do the rexis is done first and then the lens are cut in the femto procedure. But I had an exactly half rexis, but the entire lens was cut. So I had to do the rest of the rexis. Pupil getting smaller after femto. This happens when you have a large number of patients lined up for femto. I usually don't do the laser procedure. One of my colleagues does it. So she does the procedure and all the femto patients come into the OT in a row, 5 or 6 of them. And by the time you do the 5th or the 6th one, sometimes the pupil comes down. And most of it, as Minu said, you can use a mydriatic intracamerally to do that. I haven't had the opportunity to use hooks for these patients, but this is another difficulty that you can possibly have. Deep set eyes, uncooperative patients for docking, flat and very steep corneas. There are now interfaces which can overcome these, but these are situations where you have to look them very carefully. And I had one patient who, after the femto, while I was about to start the phaco, had started getting breathlessness. So normally a patient like that, probably we wouldn't have proceeded. But since the femto was already done, I went ahead with the phaco, finished in about 5-6 minutes. But by the end of it, he had severe breathlessness. He actually had pulmonary edema, had to be shifted to a nearby hospital. He recovered after that. But these are situations, where once you've already done the femto, you have to proceed. These are situations where, you can be in a bit of difficulty. So in summary, FLACS is definitely here to stay. Repeatability and precision of the incisions and the lens cuts are definitely superior to the manual ones. Obviously, more and more refinements will come into this technique over a period of time. I'm sure the refinements have started happening, and you should have a proper case selection. Don't try to do femto in every case. So whenever you have any of these difficulties, a small pupil, extremely hard cataract which you are not sure whether you want to do a phaco itself or you want to do an SICS. So these are situations where you don't think that femto is a magic, it can deal any sort of cataract. Please don't have that impression. So thank you very much for your kind attention.
Thank you, Dr. Sai Kumar, on your views on phaco-femto clash. Now the topic is open for discussion.
And Sai, before you leave, that IOL, if you're doing it at a large rexus, it's fine. But then how did you make sure that the laser did not hit the lens on the phimosis?
Yeah. Actually, there was a small space between, in the OCT, it could be seen, there was a small space between the anterior lens capsule and Dr. Lakshmi, who does all my femtos, told me that she actually reduced it. If she had done slightly more, area, probably the rexus would have been cut. But then we were afraid that we will hit the anterior capsule. So that is probably why in the thin areas of the capsule it got cut, but the thicker areas of the phimosis it didn't cut.
But even then you would have made a 5 millimeter larger one.
Yes.
It will be cut on the anterior capsule, means will be very far away.
Yeah.
Not in the center.
Yeah, it won't be in the center.
Okay. And which cases, before we leave stage, maybe we'll put another, which cases would you say no to a femto?
No, I don't do it for extremely hard cataracts. Wherever I think I will do an SICS and not a phaco, I would say no for a femto also. That is number one. Number two is patients who I feel will be very, very uncooperative for the actual femto procedure. Patients with significant tremors, head movements, who just can't cooperate for the forms of femto laser. Because many of them, you do the femto laser just for the sake of doing it. When you come, the incision may be slightly away from the, too limbal. You will have to struggle to open it. The rexus may not be complete. There may be tags there. And many a time, halfway through procedure, the suction is released. So where they're, very difficult to cooperate for the femto procedure, I would rather do a phaco directly and not a femto procedure.
Just because some patients get offended by telling that laser is not possible for you.
Absolutely.
So I sometimes just do a rexus for them.
Yeah.
And just do a rexus femto and then say that laser has been done, means they are psychologically they are
even day before yesterday, I had a patient who was on a wheelchair and who couldn't even sit on the wheelchair properly, drooling, and the bystanders had come from abroad, to make sure that they get their dad gets the best treatment. They were insisting on a laser, and they were very offended. Why laser can't be done for my dad and things like that. So I think very, very valid point that Minu has made.
We had to shift one patient with pulmonary edema from under the femto platform itself. He was lying there, and then after some time he was telling some little breathlessness, cough and all those. Then I told anesthetist, please auscultate. And then he said there is Krebs. So then we had to abandon from there itself. That is the main problem. Once you do that and then they wait for some time, then you get stuck. You can leave them go, come after 4-5 days, that's fine. But then still.
So these sort of patients, significant comorbidities, you think you're going to have trouble, I think better to directly do a routine phaco.
And after a week or so, what happens now, if you postpone the phaco part of femtocataract surgery, after a week or so, you're seeing all the air bubbles are absorbed, your capsular margins are fibrous, and that is the easiest cataract you can tackle. I had two patients. After a month, it would be much, much better actually. Your capsulotomy is...
Some people it opens up and the cortex starts leaking up and they develop inflammation and glaucoma, and if you don't
we shall now humbly present a memento to our guest speaker, Dr. Anaka Herur. I hereby invite Dr. Sai Kumar to present the memento on behalf of KSOS.